Welcome back to Tales of Abundance. We're here for another episode today. This one is going to be me, Dr. John Oberg, with my co-host again, Randy Lawrenson. Here we are, Randy.
Hi, good afternoon. And today we are going to go a little deeper in something on the episode introducing you. We mentioned Precina and we said we would dig into it deeper in the future. And that is this episode. So you ready to get rolling?
Precina Health. Yeah, let's do it.
Okay, great. Well, John, let's just start out. Precina has a bold mission to solve diabetes and chronic disease.
Yep.
Nothing like easy problems. So
Yeah.
tell us a little bit about what you're trying to do and tell us about that mission.
Yeah, Precina Health is a medical practice that does telemedicine, and it really was an extension of when my mother-in-law got sick and had a type 2 diabetic event, ended up in the hospital, and unnecessarily. And so I went back to college, got my doctorate, and worked with Dr. Dustin Williams, who's partner medical doctor. We created a new set of medical protocols that include medicine, mental health. It includes evaluating the social determinants of health, psychosocial factors. We look at all those things to help patients get their diabetes and other chronic conditions into control. We've been really successful with it.
Okay. So for the listener, I mean, we've all heard of diabetes, but how big is this problem? I mean, is it millions? Is it tens of millions? Is it hundred? I mean, how big is this problem?
There's about 33 million people in the U.S. that have diabetes that's been diagnosed. There's, we're not sure how many more, but maybe up to 8 or 10 million more people in the U.S. that have this is all type 2 diabetes. There's two kinds of diabetes, type 1 and type 2. Type 1 means that essentially your body's not creating insulin. Type 2 means that your body is resisting insulin. So still making it, but resisting it. Two very different problems, two very similarly named diseases that get treated very, very differently in a lot of ways.
Okay. So in worldwide, how many people, ballpark?
I mean, gosh, 8% of the world, 640, it's going to be, 3.5 billion people have chronic disease of some kind. And, I'm guessing, I have to go back and look at the numbers most lately, but it's going to be close to 1 billion people that have type 2 diabetes.
So let's talk about, what happens if it's not treated, right? Like my mother had diabetes, and when she died, we didn't even know she had diabetes. She didn't know she had diabetes because she never went to a doctor. But when she died, when she was in the hospital, they did a blood test or whatever, and they figured it out. So what happens when people don't treat it? I mean, what are the consequences?
Yeah, I think it can do a lot of things. It can cause organ damage. It can lead to other complications and problems. And eventually, what it really leads to is a shorter life.
Right. Okay.
And it can lead to a more miserable life. Like, diabetes can lead to amputation. It can lead to loss of eyesight. Just bad stuff.
Yeah, fun stuff.
So
there we go.
Dying is one problem.
Right.
Losing limbs, and there's also people that have tingling sensation in their limbs they can't get rid of. So lots of problems.
Okay. So properly treated, properly diagnosed, what's the difference? I mean, what impact does this have on people?
Yeah, I think once it's been diagnosed, it still has to be treated. And for some people, they can actually reverse the disease and not have any more problems with type 2 diabetes. And there are some people that there's enough damage that's been done that it's not reversible. It's just controllable.
Mm-hmm. Okay. I'd be remiss. This podcast is Tales of Abundance, right?
Yeah.
Why settle for less? So how does that apply to somebody with diabetes, right? I mean, what is what you're doing at Precina? How are you helping create more abundance in their life?
It's a fair question. I think there are a lot of patients we've dealt with that have had type 2 diabetes for years or sometimes even decades. And they're just frustrated. They're frustrated that they are still in uncontrolled chronic disease land. And they come to work with us, and weeks and sometimes a few months later, they've controlled their disease, oftentimes for the first time, and they feel like they're getting a different type of care than they've ever had before because we have a different set of protocols than they've ever had before. And this is not to knock endocrinologists or primary care physicians who are treating diabetes every single day, many times successfully, but the truth is that oftentimes endocrinologists and primary care providers are frustrated, just like patients are, that things aren't getting better. The American Diabetes Association has 500 and some recommendations for physicians on how to treat diabetes. several hundred of those are about patient self-management. And we've known about these self-management things for a very long time, and yet the problem was getting worse. And so we want to make the problem better. And so now, Dustin and I have written a series of protocols that use existing medicine, existing devices, everything that's needed already exists so that patients can actually get better. And it's good not just for patients with like the best medical care in the world available. This is something that can be done in rural and low income populations.
So what did you call it? You called it patient self-management?
Yeah.
What? Let's dig into that. What's the problem? What generally goes wrong there?
Most often, and I'll hyperbolize a little bit here, but most often somebody is told to eat better and exercise. And I think most people know what it means to eat better and exercise, but they don't do it. And so the doctor's told them what to do. The patient says they know what to do. The doctor might even say, "Do you know what that means?" And the patient will say, "Well, yes." And they come back 3 months later and it hasn't been done.
Right. That's most people, right?
Right.
So how are you different?
Well, we take a lot more time with patients on the little things. And so we take a 5-phased approach where the first phase is all about assessing exactly where the patient is. And that's a big part of the difference, is that I created a chronic disease triage and treatment planning tool in my doctorate where a physician, and sometimes with the help of a mental health clinician, sometimes just the physician, will look at all of the mental health conditions all of the medical conditions rather, that a patient is, faced with. Then they'll look at the mental health conditions that may be related to that disease state. So someone might have anxiety about their diabetes. They might have depression about their diabetes. They might have stress about their diabetes. And then we also measure the social determinants of health that are actionable, and then the ones that are not actionable we measure as well in some cases. We look at some psychosocial factors that help us to understand what the patient can and will do, and then we evaluate what's called readiness for change. And so we look at what the patient's most severe issues are, we look at what they're willing to change, and then we help them change the things they're willing to change, and we start really small. So usually it's about making sure the patients are taking their medicine on step 1. So phase 1, take your medicine.
How are you doing that?
Yeah, we're using all types of artificial intelligence and all the latest technology. But at the end of the day, we ask the patients to track when they're taking their medicine, and if they don't do it, we gently and appropriately find out why.
Okay. And how does that differ from the traditional approach?
Well, most doctors, they give you medicine, they tell you to go home and check in 2 weeks or 4 weeks or 3 months.
And you're checking in when?
Well, the next time they're supposed to take medicine. And so if someone doesn't take medicine, we will check in with them and say, "Hey, what's going on?" And so you might have heard about things like remote patient monitoring, and there are lots of physicians who are getting paid to handle remote patient monitoring. And it's incredibly effective at getting people the right doses of what they need when they need it.
Okay.
Most doctors don't have time to call a patient who hasn't taken their medicine for a day.
Okay.
We do.
Let me try and summarize this, because there's a lot coming here for me and I think the listeners.
Yeah.
So in a traditional approach, if somebody's supposed to come back in 2 weeks, they give them 2 weeks of medicine, and that's the next time the doctor checks in, right?
Could be, yeah. Usually 3 months, but 2 weeks could happen.
3 months, better yet. Okay. If they're supposed to take medicine daily, is that normal?
Yeah, what they'll do is they'll put it into their remote patient monitoring system, and then we have the time, energy, and protocols so if someone's not taking their medicine, we know how to engage with them in a way that's productive, healthy, and helpful to the patient, so that if they're not taking their medicine, we find out why.
But you're finding out daily.
The next day after the appointment.
How is this possible?
Well, they put into their application that they did or didn't take it. If they didn't, we can then reach out to them and say, "Hey, what's going on?" Let me give you an example. We had a patient who was in control for a number of months. And all of a sudden, out of nowhere, their blood sugar spiked for a day. And it spiked in a really nasty way. So a provider got in touch with them and said, "Hey, just checking, everything okay?" And they said, "I'm in Miami visiting my in-laws. I just ate a whole pizza. I'll be fine by Monday." Didn't have to worry about that patient.
Okay.
Now another patient entered in a blood glucose number if you're below 70, that's really dangerous. Backing up, diabetes is about high blood sugar, but if you have low blood sugar, that can be dangerous too, especially if you're taking insulin. This patient put in their blood sugar was 12.
Oh.
Now, that's pretty bad number. Like, you're probably in the hospital, and if it's even possible. They probably meant to put in 120 or 102, and some button didn't get pushed, but they put 12. And I happened to catch it. We're not an emergency system. We don't monitor in real time, but I happened to catch it. It was Friday night. I was ending my day. It was about 9 o'clock at night, and I just happened to be looking at something. And I called their home phone, and they didn't answer. And so then I called their cell phone, and they didn't answer. And then I called Dustin and said, hey, Dustin, this probably is not a hypoglycemic event. It's probably just a mishit button. But if it is, and we don't do anything about it, he's like, yep, you're right. So I called their emergency contact, no answer. I texted their phone, no answer. So we called 911. We had the ambulance show up with the fire department, and they knocked on the door, and they were watching TV. They were totally fine. They just put the wrong number in. Fire department called me back and said, your patient's fine. And then the patient called me and said, hey, Dr. Oberg, really sorry about that. Like, didn't realize you were checking. It's like, hey, normally we don't check this closely, but we were concerned that there might have been something really bad going on, and they haven't missed an entry since.
Wow. It's, I think I speak for everybody listening that is very different than the experiences that most of us have when we deal with a doctor or deal with, any kind of healthcare, right? I mean,
yeah, and it's not the doctor's fault. Like I went to get my doctorate, and what I did is I recognized how the system was set up for medicine today, and at the end of the day, broke down the entire patient experience and the entire doctor's experience and rebuilt it from the ground up. And then we did it in such a way that it was affordable for the insurance companies. So the insurance companies are paying us and saving money by allowing us to run through all of our protocols the way that we do.
Okay.
And so, if you keep a patient out of the hospital, a really sick patient out of the hospital, a payer might save $50,000 or $80,000, in that one hospital visit.
Right.
So if we keep patients, like we kept 83% of our patients out of the hospital for 2 years.
Wow.
Who were really, really sick patients. And so that saved, the estimate they gave us was that for every dollar spent in a system like this, the payer saves net $4. So save 5, spend 1, save 4 total.
It's good math.
Yeah.
Don't have to be that good at math to figure out that's a big win.
That's it.
So
that's it.
Tell us about some success stories. I mean, you've given us numbers and given us a couple of examples,
Yeah.
but and clearly it's medical confidentiality. You can't use names. But
Right.
But tell us a couple of your biggest success stories.
We got so many interesting ones. We had a patient a couple months ago now, that their wife called in with them and was appropriately talking to our providers with the patient. The patient had early onset dementia and was only eating ice cream and drinking chocolate milk. That was the only way they were taking calories in.
Sounds delicious.
Yeah, well, not great for blood sugar. And so they weren't willing to change their diet. So our providers smartly, and they were trained, they said, well, can we change the type of ice cream they're eating? And in changing the type of ice cream alone, dropped their blood sugar 100 points in a week.
Oh.
And then there's confidence of the patient at that point to make other changes, right? And so that's just about how you build trust with a patient, right?
Mm-hmm.
We had a nurse who was diagnosed with type 2 diabetes in the hospital emergency room. She forced them to take her blood sugar, and her A1C, which is A1C measures how your blood sugar's been for the last 90 days. And 7 means you have diabetes. Hers was 14, which is really, really bad. And she didn't want to take insulin. And we weren't really excited to hear that, but we said, we'll work with you. And 6 months later, her diabetes was fully in control, under 7%. Now, remember, if you get a drug that reduces A1C by 1 percentage point in a year, there are people that would tell you that's $1 billion drug. And there are GLP-1s right now that will drop blood sugar by, 1% every 4 to 8 weeks. But we did that without using insulin. We helped her drop 1% of A1C per month for 6 months and changed her life, and never had to use insulin.
It's great.
Yeah.
Wow. So obviously you have to have a you can lead a horse to water, you can't make them drink. So
Yeah.
you've got to be able to empower. Is this empowering to your customers, your patient? I guess patients, what is what you want to refer is what they're referred to as
Yeah.
or are. But
Well, remember, we measure readiness for change.
right,
And so if someone's ready to change one thing but not another, as long as there's nothing emergent and severe, we're going to help them change the thing they're ready to change. And when someone is ready to change, makes a change, sees a result in very small ways, we can then say, what's the next thing you're ready to change? And we can use techniques like motivational interviewing to help people, become a touch more motivated. But the reality is that people are ready to change some things and not other things. And so we do a really great job of meeting the patient exactly where they are.
So I want to go back to my mom. My mom didn't have diabetes, and getting her to go to a hospital would have probably had to been at the end of a gun.
Yeah.
But let's assume she went in, and I know what would happen if she did go to. Part of the reason she didn't want to go is the doctor told her you should quit smoking.
Yeah.
She didn't want to hear that.
Yeah.
I'm pretty sure it would have been the same conversation with diabetes. So you get somebody like her. She's stubborn, amazing woman, right? Love my mother was great, one of the nicest, sweetest people you could ever meet, but stubborn.
Yeah.
She comes in. She's got diabetes. She doesn't want to change her lifestyle.
So I'm going to tell you a real story instead of your mom. So we had a patient that came in, did not want to use insulin, didn't want to inject insulin. They did not want dialysis. And they were really convinced of that. And they were going to be dead within 60 days if they didn't do those things. And so I called the patient and said, hey, look, I understand from our medical team that you don't want to take insulin. Now, I want to remind the listener, I'm a doctor, but I'm not a medical doctor. I'm a social work doctor. So, right, I'm the mental health guy. So I called and said, hey, I understand from our medical team that you don't want to take insulin. And he said, that's correct. And he was like, serious about it. I was like, great. I just want to let you know I support that. He's like, oh, you're great. I said, yeah, I heard you don't want to have dialysis either. He said, yeah, I don't. I said, great, I support that too. I wanted to make sure that we got you a good referral for either palliative care or a good estate attorney. He said, well, what's that? I said, well, those are the things you need when you're going to die because you've got about 60 days to live. It's in your medical chart. Your physician shared with you that you're 60 or 90 days from being dead. And I just want to make sure that your family has their affairs in order. So I'm here to ask, how can I help? He's like, whoa. Wait, say that again? And I was very non-judgmental about it. I was like, hey, look, I support your decisions. These are your choices to make. Now, if you think you can choose not to die and choose not those two things, that's not a choice you get. So not choosing A or B gets you C. And he said, would it be okay if I put my daughter on the phone? So we got the appropriate medical permissions to get his daughter on the phone, and I explained what was going on. And by the end of the day, he had insulin in his house and he was injecting insulin. But he was scared. He didn't know how to inject insulin, didn't know what it meant. So we had to take people through the process of like, here's how you inject insulin. Here's how you make it work for you. Like, answer all the questions. Like, I talked to a patient just yesterday who no one taught them how to inject insulin when they were prescribed insulin.
Wow.
So we did that work for them and said, and again, I don't think that's every medical provider or every hospital experience, but it happens often enough that people are jaded by the system more broadly. And all we want to do is be the glue. And I do mean every single primary care provider that I've talked to has been supportive of the work we do, skeptical sometimes at first until they hear what we're doing, but supportive in the end because they know their practice isn't designed to be able to do what we do. And we definitely do not displace the work that primary care providers do. We're just glue. All we're doing is supporting the work they're doing. We have a lot of cardiologists who refer patients into us because cardiology and diabetes patients oftentimes similar patients. And so a lot of cardiology patients get referred to us to help with diabetic issues. Mm-hmm. And same thing, I think doctors could be skeptical because they don't understand how we fit in because we're such a different medical practice. But what we're doing is we're providing a glue between the existing system to help the existing system work. I was talking to an insurance company a few weeks ago, and I said, I'm not here to be a care coordinator. You have care coordinators. I'm here to make sure the patient calls the care coordinator. I'm here to make sure the patient knows what questions to ask the care coordinator and the patient learns how to engage in their own care. And that's what we're trying to do, is help the patient get really educated about how they get involved in their own care, but only by meeting them where they are, not by just educating them and then the patient not actually understanding the education and it failing, but really meeting them where they are and being patient, eh, pun not intended, but appreciated, by being patient with them and actually holding their hand through the process.
How much of this is psychological, emotional of their journey, their challenges?
I mean, Randy, every decision humans make is made emotionally and then it's justified logically when you get down to it.
Okay. But how do you help people through that? If, I mean, are most of your patients, is this something they're grappling with because it's new, or is it more they've been dealing with it for years or decades, or both?
It's all over the map. I think there are people that are resigned to the fact that it can't change and prove me wrong. There are people that have been frustrated because one patient, 20 years, they've been uncontrolled
Right.
and didn't know how to handle it. We have patients that are newly diagnosed. We had one patient who had just had a limb amputated because they didn't treat their diabetes well enough and they were finally ready to get serious about it. So it's really all over them. I talked to someone yesterday again who called and said, "Hey, I am committed to doing whatever it takes, but I just moved from one city to another, don't have medical care in the new city. I'm not sure what to do." And they're a personal friend, so they knew that I was dealing with this, and they said, "Would you be willing to help?" This morning I had someone who called and said, "Hey, I just had a family member who was diagnosed 2 weeks ago, and our doctor's appointment's coming up. We don't know what questions to ask." So, you know, people want to do good. Physicians definitely want to do good, and they're generally good at what they do. But there are times that they just don't have the time to follow up in the way we need to when someone's dealing with a complicated issue.
Yeah.
A broken arm and diabetes are treated very differently.
Right.
I'm being a little tongue in cheek here, but you put a cast on someone's wrist, it's not going to come off until you take it off.
Right. Okay. So when most people think or healthcare these days, they think, "Oh God, it's expensive,"
Yeah.
right? And you're talking about exponentially better results. Let's talk. And you mentioned a little bit earlier that you want it saving, but I mean, what's the financial impact for customers? Let's go a little deeper into that.
Yeah, I think so. There's two people that are paying the bill. There's the payer that pays the bill. That's the insurance company. And then there's the patient. And so if you can keep the patient out of the hospital so they're not having to pay for the hospital visit, and you can keep the payer from paying for the hospital visit, it may cost a little bit more from office visits, and it may cost a little more for the medicine, but that pales in comparison to what one hospital visit can do. One hospital visit from one patient can wipe out the gains for 8 or 10 patients. I don't know the exact number, but
Yeah.
a big number of people. And so, it's that a stitch in time saves 9 stitches later.
Yeah.
So that's what we're trying to help people do. Now, we also make sure that we can see a lot of patients by using technology inside the practice so that it's financially feasible to do what we do.
Let's go deeper there. So I know well enough to know that you're doing a lot of work with AI.
Yeah.
Right. What can you tell us about that? I mean, that AI is its own whole own podcast or multiple podcasts of its own, but whether it's AI or other technology, like what is that doing for you as a company?
Sure.
And more importantly, for your patients?
There's a lot of the stuff that everyone's doing, like we're creating content using AI, and we're using AI for chat bots, and we're like all those basic things. We're starting to employ that now. We're also developing a patient co-pilot where when the patient calls in, they have an AI specific to their case that can help them navigate things without hallucinating. That's the key. Without hallucinating about anything on their case that's medically important. And we're ready to deploy that coming up this year. And that'll save...
By the way, by hallucinating, for people that aren't familiar, ChatGPT or a lot of the AIs are well known for giving you really great answers 80, 90% of the time, and then 10 or 20% of the time they don't know what they're talking about, and it just makes things up.
But it sounds really credible.
Yes, it sounds exactly the same
Yeah.
as the 80% that was
That's
right. So
That's right.
I think just If people don't know what that
that's
term is.
dangerous in medicine, right?
Right. Well, yeah.
Yeah. And so we have a patient co-pilot that we're developing that doesn't have the ability to hallucinate from a technological perspective. We've done some things to make that not possible. And so obviously it'll go through rigorous testing before we put it out with patients. But so far we've had great success in testing, and we're pretty excited about that. And then, AIs are being used to scribe and transcribe things for doctors to save time, and we're obviously doing that as well. We're also creating AIs that can help just answer non-medical questions for people, where it can go into a database and search after hours. And then doing things like scheduling, we don't require our patients to have an appointment in the same way that a medical office does every time. Sometimes an AI can just pop onto the phone with a patient, take their information, get it into our database, and if they need a 5-minute call with the provider, just put that onto the calendar and make sure the provider calls them back. And so we're lowering the cost of care in a lot of places so that we can spend time with the patient. And then some other things that we're doing that are really important. I was talking this morning with someone about how most people working in AI fail to code for sentiment analysis appropriately. I mean, there's science around this that is just being missed.
For listeners' help, for me, sentiment analysis is what?
Yeah. So if I said, hey, your sentiment on the phone is happy, sad, you want to hear more about this. Oftentimes, the patient isn't leading the provider to the right answer. The provider has to lead the patient to the right answer. And so if an AI, if someone says, I'm not interested in doing that right now because I'm really busy, that could be code for, I don't feel smart, you made me feel stupid, I don't want to deal with this because it's uncomfortable, and it has nothing to do with them being busy. But if the AI tells either the provider or itself to answer the question around being busy, it's not tracking sentiment appropriately.
Okay.
Right?
Yeah.
It's not calculating what could happen if someone feels shame, embarrassment, fear, And so we have AIs that are guiding people and guiding itself through that, and we're coding that into the AI so that when the AI is not certain what the sentiment is, it's like, hey, here's the thing being picked up on, summarized, but I'm not going to give you the wrong sentiment.
Okay. Great. Let's look ahead. What's the future look? I mean, where do you see Precina moving and going, and what is that like? What is that future?
Yeah, I think we're going to get into a situation where we work directly with the insurance companies and hospitals to identify patients and to lower the cost of care even further. There are things you can do in direct pay contracts where you can wring out some of the administrative cost as well, and I think we can lower the cost even more. We're designed to be cost effective in kind of the Medicaid population where it's, harder to serve patients, and we're designed to be able to do that really, really effectively. We think we can lower the cost even further over time. And then I think at the end of the day, we're going to find these protocols are going to end up being a different subspecialty of medicine that is a part of internal medicine, but different than primary care, different than cardiology or endocrinology or any other subspecialty, where you're dealing with complex conditions that require handholding, and we're going to find ways to do that that feel great for the patient, that get amazing clinical outcomes, and are able to be cost effectively taken to market so they can be done at scale.
So we've been talking really about diabetes.
Yeah.
At scale, is this scalable, transferable to other areas and other things?
Some. I mean, to handle diabetes well, there are some mental health issues that we have to address. And we're in discussions right now there's a couple of clinical studies that have been done that indicate we might be able to reduce the cost of the type of mental health care we need to provide by 98%.
Wow.
98% reduction in cost, and create more bandwidth for mental health care in the places that we can help with. So there is some scientific papers have been written about this. It's really exciting early work. I think within 6 months we'll know a lot more, but we think we can reduce, and again, this is a very narrow part of mental health care, not all of mental health care, but in this one narrow area, we think we can actually reduce the cost by 98% and increase the bandwidth, geometrically.
I want to dig a little bit more. I want to go, kind of back to where we started about the journey. This is a radically different approach, at least my perception of healthcare in America.
Yeah.
Like, you can talk more about like how did you get there? Like what I know but what allowed you to approach this from such a radically different approach, right? Because if everybody keeps doing things the same way, you're going to keep getting the same results, which has really just led to healthcare, healthcare going up and up and up.
Yeah. I've been involved in healthcare for a long time, and I was the company that I started back in 2014 was a healthcare payer, so we're really familiar with the administrative costs of healthcare and how you have to wring them out on the payer side. But I was convinced there was things that could be done on the provider side as well. And so when I went back to get my doctorate, one of the things as a part of my program that I was encouraged to use was called design thinking. And design thinking was about really starting from the beginning and doing, for me, hundreds of stakeholder interviews. And there was no sacred cow. It was like we were willing to break down the entire practice of medicine and build it back up. The only thing that I required when I built it back up was that it work inside the existing system from a payment perspective so that you weren't trying to change both the practice protocols and the payment protocols at the same time. I felt like that would be a bridge too far for people to swallow. And I've talked to a lot of chief medical officers at insurance companies who thought that was the right approach. And so we said, okay, if the boundary lines are you have to use the existing economic system, but you have to radically change the system to make it cost effective and number one, clinically effective, and then a good experience for patients, what does that look like? And many failed attempts, right? So we went through and designed something and then went out and did interviews, and we had experts show us like, hey, that's not going to work and here's why, and that's not going to work and here's why. And we kept at it over and over and over again. And, design thinking is not something that was a part of USC's program like that. It came out of Stanford's design school, as best I know. I used a book that was written by professors at Columbia University as kind of my template for design thinking, but it's about rapid iteration. It's fail forward, fail fast. We just couldn't do it inside of a clinic because a clinic needs to be safe, right? And so the way we did it was we proposed these things to experts, people who have decades of experience, and then we talked to patients. Hey, what does this do for you? What's the big problem? Does this solve your problem? Treatment burden was one of the far bigger problems than I ever anticipated. I talked to patients who were taking 15 medications across 5 time windows in a day, and they didn't have time to go see more medical appointments. They had a hard time getting to the pharmacy to get their medicine. And so we realized there was all these little problems along the way that we had to intervene with if we were going to solve the problems that we said we were going to solve.
It occurs to me that like you being able to disrupt this, a big part of it is because while you're a doctor, you cut your teeth and your background was more from outside the industry.
Right.
And coming in. You want to talk to that? Like the advantage of not cutting your teeth or growing up in that industry versus people inside?
Yeah, it's bifurcated, right? I joke that my first job in healthcare was 8 years old. I was filing charts for my mom's medical office because I was homesick from school one day, and she wanted me working instead of homesick from school. So I was filing charts in her office, and they were orthopedic surgeon's office. By the time I was 12, I joked that I was like, developing X-rays and like in film. Yeah. HIPAA wouldn't have that today. OSHA wouldn't have that today. But my grandfather was a surgeon. My mom ran a medical practice. I was in an HIV lab at USC when I was 19. So I've been around healthcare. And when I was doing consulting, in the consulting part of my career, I was consulting for, different types of healthcare practices on the business side. And I still consult for healthcare practices on the business side, but I wasn't involved clinically.
Right.
And so when I got involved clinically, first I had to find clinicians who were willing to go along for the ride with me. Dustin Williams has been an amazing partner and collaborator. We've got advisors, a ton of advisors on our company, medical doctors, healthcare clinicians, like lots and lots of really smart people, scientists who deal with sensors, and all the people you need to say, hey, look, we've tried that before, it didn't work. We've tried that before, it didn't work. We've tried that before. I've got one advisor who's on our board who's been the CFO of, healthcare companies for 4 decades, 26 different subspecialties. I wanted that kind of experience sharing with me, like, how does it work and how does it fail? How does it work and how does it fail? And so again, hundreds and hundreds and hundreds of interviews to figure out, like, okay, what about this? And then what about this? And then what about this? And then we put it together, and we've had almost 300 patients go through our system now, and we're seeing similar results to our pilot study. We were just approved by an institutional review board to do a scientific retrospective on the work we've been doing for the next 300 patients. So we'll start writing academic papers about that in a case study methodology, and then we'll start doing more clinical research, I hope, in the future to show that these protocols do actually create real healthcare outcomes with real economic value to people.
Great. Let's talk about challenges. So let's start with along the way. I mean, it hasn't, it's never easy, right? Especially doing, this is thinking big and something of this scale. There's got to be challenges. I mean, tell us some of the challenges or bigger or more interesting challenges have happened along the way.
Go-to-market's always the toughest. Like, recruiting patients and letting people know you have this new way of doing things is always the hardest thing to do. And so we just need more patients. We've got, 1 billion people in the world who have this problem, and people don't know that we're doing it. And part of that's my fault. I tell people I'm a horrible self-promoter. I just need to get out there and tell the story more often, which is, I appreciate you letting me tell the story today. I need to tell the story on 100 podcasts or 1,000 podcasts, or, and let people know that we're doing this. And then we need to find partners who can, payers who who are innovative, who want to make the system better, not just for the patient, but for the physician, for the provider, for the payer. I truly wanted a win-win where all of the stakeholders win. Like, we don't take the place of a primary care provider. We don't take the place of a specialist. We don't take the place of a diabetic educator. We don't take the place of a dietitian. We don't take the place, go on and on. We're not a care coordinator. We're not a navigator. We're just the glue between all those things to solve the problem that all the patients said they had with all those providers, not because any one of those providers was doing something wrong. There just isn't glue in the system.
So to take that and dig down a step, who is your ideal customer? Who is your avatar?
Yeah, we have a couple, right? So on the payer side, we want payers who are innovative, who have patients with diabetes, which is every payer, and who, they want to see clinical gain, and they're willing to take the economic gain along with it. So right. I think that's most payers. And we need to start with payers who are willing to start with a small practice. Like, we can't take on 100,000 patients tomorrow, but we could take on 5,000. And so that's who we're talking to today. So is in terms of like a client, that's our perfect client. In terms of a patient, our perfect patient is someone who's really struggled with diabetes. You have diabetes if your A1C is 7. If you're above 9.5, you need some help. And so I'd prefer the patients at 9.5 and above than 9.5 and below, because there's more opportunity for us to help them quickly. Can we help patients that have 7.5 A1Cs? Yes, we have. Yes, we will. We'll continue to do that. But our heart is for the people that are low access to care, lower income, really bad problems. That's where we really have focused our time, energy, and attention, is the people that other people say that market's too hard. I've said we're going to address that market head on, and we can do it.
Taking that a step farther, what challenges do you foresee in the future?
Yeah, I think, look, like many new companies, we have a go-to-market challenge that we're trying to get the word out there from a marketing perspective. We've got a funding challenge, in that every company who's young has more opportunities than they have money. Mm-hmm. I've put a lot of money into this personally, and I say a lot, I mean a significant portion of my net worth. And then, we have technology challenges in that we want to be really innovative. We believe we can lower the cost of mental health care dramatically, as I mentioned. We think that our protocols have similar enough work. We're doing some work with hypertension and cardiovascular disease, and we're seeing similar types of clinical outcomes with hypertension. We think that'll be truthful. We think that'll be the same as congestive heart failure and pulmonary diseases like COPD and asthma. And then we think we can take these protocols and leverage them in other parts of medicine, where we'll give people the science that we have learned and said, here's how we improve medicine in other places. The problem is that what we're doing isn't sexy. Like we're doing the roll up your sleeves and put your hands into the mud all the way up to the elbows type of work. The providers that work in our offices are getting trained weekly in continuing education, not monthly, not annually, but they have continuing education every single week. They have to go, and it's stuff they didn't learn in medical school.
Yeah. You're blocking and tackling.
It's it. It's the fundamentals, and you won't be shocked to hear this. It's the fundamentals of how that professional relationship can be better and more effective and performative, if performative is actually a word.
Is there anything, I get the feeling if somebody has diabetes, traditionally, they're kind of on their own. They might know other people with diabetes. Is there anything about a community there that
I think there's a lot of diabetes communities, and I think that there's, we hope to engage in those diabetes communities and to have diabetes communities of our own, both and.
Yeah.
And I'm really excited about the diabetes communities that are out there. I think that like any community, there's some really great information out there, but there's also some noise. And so I hope that as we engage in that community, we can be a community member that cuts down the noise and really crystallizes the thinking, and we can help providers give better language for the patients, whether they're providers of Precina or not. We hope that we can provide a better communication path, because there are people other than Precina who are helping patients control diabetes. We're not the only ones doing it. We're just the only ones doing it at the level of effectiveness that I've seen. And I had to study that,
Okay. So thinking about what you've done, and you're still a fairly young company, right?
Yeah, very young, yeah.
What's been the most rewarding part of it so far?
I mean, talking to the patients, when the patients are thankful, that's got to be like number one on my list, like 1A. 1B is working with the providers we work for. We have some advanced practice, like physician's assistants, physician's associates, and nurse practitioners that work with us. And one of them shared with me, they said, I used to work with a medical practice that every few months we'd have one of these success stories across the whole practice. We'd all talk about it and celebrate it. And now I have success stories like that twice a week myself.
Love it.
And so we're reducing burnout and we're giving a really high level of satisfaction to our providers who are seeing the clinical outcomes they went to school to be able to see. And they love that. And so I think, 1A, the patient conversations, and 1B, the provider conversations. Mm-hmm. Like if I could spend all my time talking to patients and providers every day, that would be nirvana.
Wow.
Yeah.
It's great. What advice would you give somebody that they've got diabetes and they just feel overwhelmed?
Yeah.
What advice? What would you say to that person?
First of all, you're not alone. Like, I think it's really important to understand that you're not alone. And then, if you're not sure what to do, reach out, like come talk to us. I'll talk to you. I'll let you know how to engage with your healthcare providers. I've done it 3 times this week for people that aren't patients of ours, where they just like, hey, I think I've got it under control, but what, how do I do this next thing? And so we're happy to help. Like it doesn't have to be a patient for us.
Yeah.
So, and then we're going to start putting out a lot of Precina content for people to help them take more agency in the journey, the healthcare journey, so they can actually be more engaged in a knowledgeable way. But it's going to require more for the patient. And that's what we're really going to do with our content. We're going to make it more for the patient. Like I just learned something yesterday that I'm embarrassed to tell you. It took me this long to learn about, disposing of needles in a medical practice. That, and when I learned it, I was like, wow, I never knew that part of it. And, the nurse and the doctor kind of laughed at me like, well, everyone knows it. It's like, no, every nurse and every doctor know that. But we're going to write like a little half-page paper on that for patients now and just say, hey, here's something I learned. And, in real candid terms, like here's what I didn't know. And here's what I know now. Okay. And, I was diagnosed with diabetes along the way, Randy. I think that's what, embarrassingly enough, I was halfway through this process where we are today, done with my doctorate, and my A1C came back at 7, and I know this stuff. I'm teaching it to people. And I was like, man, I'm not doing it though. And so I started doing it and I lost 60 pounds. My A1C is down to 5. Like I just decided I was going to be the best patient in the practice.
A1C, by the way, is what?
That's hemoglobin A1C is the measurement of your average blood sugar over the last 90 days. And you want to be below, perfect world below 6.5. 7 is you have diabetes. And, but yeah, so I mean, at 5, you're like, my doctors are ecstatic. I have a primary care physician who's like, you're my favorite patient ever. Like, this has been great for you. I was like, well, I do teach this stuff. Like, if anybody can do it, it should be me. But I wasn't.
Right.
Like, even though I knew, like, knowing isn't enough, I had to actually go do it. And that meant engaging my primary care provider, asking Dustin for help, being humble with my team, like, hey, I'm also impacted, and having a community around me instead of being holier than thou about it.
I think that's really great for people to hear, right? I mean, you teach it and still struggle with it. So
yeah,
so back to the part, people are not alone. There's help there. Let's take that person. They're overwhelmed. They come, they work with Precina, they get help. What does that look? I mean, what does their future look like?
Yeah.
How does their life improve?
Phase 1 is 30 days. That's where we go through the entire evaluation process and we start people making small changes. Phase 2 takes a few months. That's where we get the disease into control. Phase 3, we stabilize all the medicines. Phase 4, we engage in lifestyle and diet and how they're going to actually start to come down off their medicines if possible. We've had a lot of people who've been able to come off of the medicine, which is a huge win for them, obviously. And so phase 4 is all about down titrating and getting people off of medicine. And then phase 5 is stabilizing those behaviors so they can have a long life without going back, and they can have that long, lifelong habits that keep them in control. And so that's the 5-phase approach that we take.
Okay. So what do you think are your superpowers, or maybe a better question is, what is Precina's superpowers? If we were going to sum it up, like put a bow on, we've talked about a lot of stuff. To sum it up for somebody listening,
yeah,
what are the superpowers of this company and your mission? And
yeah, the hard part about Precina is it's 100 little things, right? But if I had to put a thread through all 100 of those things, I think we're exceptional at meeting people where they are. We're great at the back end, making sure that it works inside the system, the finance, the AI, the technology, we're good at all that. But meeting a patient right where they are and then taking them to that one next step, I think that's the thing that makes us really different. And not that most doctors don't want to or know how to or do that for a moment. Their practices aren't set up to be able to do that for a patient every day.
Okay. And what's the best piece of advice that you've received, that has helped you on this journey? Like what's a piece of advice or wisdom that's really just helped?
That's a tough question. There was and I don't remember I wish I could remember which research paper it was to cite this for you, but I remember reading research that while we celebrate as a society the Michael Dells and the Steve Jobs and the Bill Gates of the world who started their company at 19 and were really successful as entrepreneurs, the vast majority of successful entrepreneurs are generally mid-50s, mid-40s. They've been in an industry for 20 years. They've seen the problems firsthand. They know all of the ins and outs of it. And that's who's successful in those types of entrepreneurial journeys. And I think that this Precina is an amalgamation of things that have been going on in my life since I was 8 years old, filing charts, and a call on my life. We talked about faith at one point in one of our conversations, not this episode, but this has been a whole lot of layers that have been put together to kind of address this problem, and it creates an opportunity for really great professional relationships to be formed to help people deal with an insidious disease that is quietly killing people in a way that is not fair and reversible. And now I think it's time we end type 2 diabetes globally. I think we can be done with it.
Okay. Well, maybe the most important question I have is people that need help. Like, what should they do? Where should they go? Whether it's a provider, it's a potential client, somebody struggling with diabetes.
Yeah.
I don't know, investors. I mean, anybody that wants to help. What help do you need, and how can how do we help more people?
Yeah, I think number one, we want to recruit more patients to join the fight, to let us join the fight with them. And so right now, we're licensed in 3 states. We'll be licensed in many more states very quickly. There's a medical license compact that allows you to get licensed in many states very, very fast. But Texas, California, Oregon today, and we have a lot more states coming online. So by the time a listener's listening to this,
so if I'm in Texas, Oregon, or California, I have diabetes and I want help, what do I do?
Precina.com, Precina, Precina.com. Fill out a contact form, and you'll be shocked at how fast someone gets back to you to hear about what we're doing.
Great.
For people that are interested in investing with what we do, you can reach out to me. I'm available on LinkedIn. I'm available at Precina.com. I'm very easy to find online. Happy to talk to investors about the work that we're doing. And then if you're interested in talking about healthcare or AI, and you want to engage in our team about what we're doing to use AI in healthcare more effectively, or just technology, I'd encourage you again to reach out to me, and we'll have conversations about what we can do to help one another. But we're really serious about changing the narrative in healthcare. And I don't want to, again, I think payers are doing a lot of things right. And certainly there's things they want to improve. I think doctors, same thing, doing a lot of things right, but there's things they want to improve. Hospitals doing a lot of things right, but there's things they want to improve. Everyone has great intentions that I talk to. We're just finding a way to make those things a reality. And if someone's curious about how to do that in their organization, and they say, Precina is not for me, but I want to know how I can do that in my organization, reach out and I'll tell you how we get it done in other organizations that we help.
Okay, great. And I'm sure over time we'll be adding more and more stuff to our website, talesofabundance.com, and our Discord and all that stuff about Precina. But look, I mean, I love this mission. I love this journey, right? I mean, and it's just, it's a need in the world. And like, I think you said it well, it's not necessarily sexy, but it's the blocking and tackling that wins the game. So
time to end type 2 diabetes. We're done with this. Let's move on.
I love that. I think that's a great way to end it. So John, thank you so much for your time and sharing this really with the world.
Thanks, Randy.
Thank you.